Welcome to The Scope with Dr. K. I'm Dr. Kaczynski. We're going to open the show today, as we always do, by stating that the goal of this show is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology, but also outside of GI as well. Today marks the start of our 5th year of this show. To celebrate the beginning of this 5th year, we have a treat on this podcast. Our guest on the show today is Dr. Mark McClellan, Director and Professor of Business Medicine and Policy at the Duke-Margolis Center for Health Policy at Duke University. Mark is one of the most sought-after thought leaders in healthcare today, especially value-based care. We are fortunate that he's willing to give us time today. He's a physician and an economist who focuses on quality and value in healthcare, including payment reform. He's had a passion for real-world evidence and a focus on more effective drug and device innovation. Dr. McClellan and his Duke-Margolis colleagues are now focused on health policy strategies and solutions to advance the resilience and interconnectedness of 21st century public health and healthcare. He's a former administrator of the CMS and a former commissioner of the FDA, where he developed and implemented major reforms in health policy. Welcome to the show, Mark.
Dr. K, it is a real privilege to be with you and your colleagues here today. I have to say, coming from Duke University, we have a Coach K, but my impression is that in the world of gastroenterology, you've got a similar kind of following and fan base. So real privilege to be on with you all.
Well, it's our privilege, Mark. In beginning, I typically start all of my podcasts by allowing the guests to tell the listeners a little bit about themselves in their own words. You've had quite the career. Tell us how you became who you are today.
Well, Larry, it was not a linear path. I didn't grow up thinking I wanted to be, CMS administrator or even a health economist or anything like that. I came from a family that has a lot of lawyers. My grandfather was dean of the UT Law School, has a number of politicians. My mother was the first woman mayor of Austin, Texas. So I went to medical school to get away from all that. I was planning to be a doctor and doing some research in neuroscience, but long story short, I turned out not to be so good at that. Fortunately, I was able to get into an MD PhD program where we adapted. I had a chance to use my applied statistics, my biomedical background, to shift into a PhD program in economics along with my MD, which I loved. I was able to do a lot of empirical analysis of how non-medical factors like payment changes and regulatory changes influence healthcare. Anyone in clinical practice knows that policy really matters. So, not surprisingly, a lot of that work showed significant impacts. And in turn, this also allowed some analysis of how the resulting changes in medical practice affected outcomes and costs. That led to my interest in things like value-based care and innovative ways of developing drugs and policy. Like my grandfather used to say, it's not the dollars you make, it's the difference you make. And I've been really lucky to have some opportunities to turn this interest in combining policy analysis with real-world impact in the public and private sectors.
Tell us about the Duke-Margolis Center. Why was it formed? What's it dedicated to?
Yeah, it picks up on pretty much the theme, Larry, that you just laid out and I was talking about, which is that our problems in healthcare are really challenging and complex, and no one discipline is able to address all of the issues that need to be addressed to make real progress. So when we formed the Margolis Center, this was after I had spent some time in government and in policy making in a think tank and in working with private sector companies and medical practice as well. We really wanted to put it all together. We were lucky to get founding grant from Bob Margolis. He's a physician graduate of Duke University who went on to start one of the first physician-led kind of whole person accountability primary care practices and medical practices in California, where back in the 90s and And even earlier, they were taking on full financial risk for taking care of a population of patients. He was one of the people who was successful at that early, and in wanting to give back to Duke, he was able to make a contributing founding endowment to our program, which is really about transforming healthcare. On the Duke University side, a lot of your listeners probably are familiar with Duke. It's got some great academic medical programs, but it's also a relatively young university. We're celebrating our centennial this year, and it's one that has a long tradition of interdisciplinary work. So when we put these pieces together, we wanted to set up a program that dealt with health policy and health reform, but not from the silo of any particular school or department. So there are a lot of health policy programs out there. We looked at all of them and deciding how we were going to proceed. We're, I think, the only one that is truly university-wide. I report to the head of our health system and provost of the university. Our faculty are drawn from throughout Duke University, and we complement that with a research staff that has deep expertise in institutional policy issues related to FDA, related to CMS, related to state Medicaid, health reform. And putting the two together, that attention to the details and relationships that matter in policy with the academic expertise has helped us bridge what I think is too often a gap between good research that's done in a particular discipline and what really matters for policymaking. Along with all of this, besides our presence throughout Duke, we also have a large part of our staff, some of our faculty based in our Washington, D.C. office, which is a really good place to be for working with CMS and other federal agencies on connecting the challenges that we're facing in policy and the political constraints and things like that with what we can do about it from a research standpoint. So we're a relatively young program. We've been here for 6 years, but we've grown a lot to the point where we're expecting to make some announcements soon about how we expect to be a key part of Duke's look to the future, where with AI and lots of supporting technologies around, what future leaders really need to focus on, I think, Larry, is being able to put together the pieces effectively, the relationships. So we have a lot of our faculty and students who are in medicine and nursing and engineering, other parts of Duke, who want to make a difference in reforming our healthcare system. But to do that, medical expertise is really important, but it's also helpful to have knowledge, relationships, awareness of how policy gets made, the constraints that federal and state policymakers are facing, what's going on in the business community, et cetera. And that's what we're trying to put together for the long run, how to really develop the research, the policy recommendations, the implementation support, and most importantly, the current and future leaders who can really make a difference in solving these problems.
I'd like to focus this podcast predominantly on payment models. I know how focused you are on that and how we use these changes in payment models to move from fee-for-service to value-based care. So my first question to you on this is, how do we begin integrating primary care physicians with primary care providers, with specialty care providers into a patient-focused model built upon high-touch proactive care? What's worked? What is still yet to be done? What are your thoughts on this?
It's a great question. I think that is, we're talking about big, complicated problems that need to be solved. This is at or near the top of the list, Larry, for the future of healthcare in this country, and I think globally for that matter. You and I have been at value-based care for a while. This notion that, especially with modern digital technologies, modern biomedical technologies, better diagnostics, more effective interventions, it's possible to move from a healthcare system that was designed and organized and financed based on dealing with problems after they occurred, things that happen in the hospital when people have downstream complications of conditions, and really turn that around to early detection of risk factors, early detections of complications in chronic diseases, and interventions that can head off those complications. A lot of people talk about how well that can save money from avoiding costly procedures and hospital care. But even more important, it makes for better, higher quality of life and longer lives for people. Not to mention that this shift away from just a medical focus, as we already talked about, makes it easier to bring in the social factors and housing issues, nutrition issues, issues that affect people, the way people behave, make decisions about their healthcare on a day-to-day basis all the time they're outside of a specialty or primary care visit. So we're making progress on that. I would say that we're getting there on more advanced primary care that has more resources, more diagnostic, digital supports. We're getting there through reforms that CMS has implemented, like DRGs and bundled payments for how to make hospitalizations and major procedures go more efficiently and effectively. But the big missing ground, what we talked about last year at PTAC and what we're focusing on as a primary area of opportunity at Duke-Margolis, is the huge amount of healthcare spending and huge amount of opportunities for medical care integrated with primary care to prevent the costly complications of serious illnesses, particularly serious chronic conditions like inflammatory bowel disease, other common ones in the US, musculoskeletal problems like back pain or degenerative joint disease, cardiovascular problems like managing ischemic heart disease or preventing its complications, heart failure, et cetera. Where if you look at medical practice, there's a lot of variation out there that has significant consequences for healthcare costs. Primary care spending is still, 7-8% of the total. The money is in the specialty care. And where, if you look at where technology is headed, there is more and more that people with specialized knowledge of a disease area can do to help individuals stay well. Look at the gene therapies and others that are coming, even eliminating conditions, not just slowing down progression and preventing complications. But we are simply not good at that. None of our payment models have solved, our payment reforms have really solved this problem at scale. We know the directions that are needed, SONAR MD in gastroenterological care, which is building supports for primary specialty coordination and supports for connecting specialists with patients, not just to see them when they come into the hospital with a IBD complication, but to monitor and predict when those complications may be emerging and how to prevent them in the first place. But we haven't yet aligned our policies and especially our finances with making those kinds of care models, which is the future of medicine, especially specialized care, the norm rather than the exception.
Mark, I'm gonna pivot here for a second, but stay on the same topic. At PTAC, it seems clear to me that risk should be borne at the level of a significant risk-bearing entity that can take responsibility for the health of a population. I like that. But then incentives have to be pushed down to the provider level, which takes us right to payment models. And so the word nesting to me is something that keeps coming up over and over and over again. We've both published and spoken on this. The question is, how do we do this? How do we take an ACO and build a structure that they're willing to nest a value-based solution for their GI providers? How do we do this?
Yeah, that's the $500 billion question for the US healthcare system. That's the part of payment reform and value-based care that's not getting its support. And I know people talk about incentives a lot and incentivizing providers, but in my experience with primary and specialty providers is that the vast majority of them are trying to do the right thing for the patient. They're just operating in a system that isn't financially aligned with that. And like I said, we've figured out some steps that help on the primary care side, but we haven't yet extended it to specialty care. Reflecting all this, as you mentioned, our group at Duke-Margolis spent some time with PTAC in the past year. We also have been working with CMS and released a specialty care reform report on the concept of nesting. That was back in late 2022. And we followed that up just recently, just in the last month, with 2 reports in health affairs forefront. For your listeners who pay attention, if you just Google Duke-Margolis Specialty Care Reform, Health Affairs Forefront, this two-part series will come up. And it talks about sort of three areas of specialty care, three kinds of specialty care that we've done a more or less good job of supporting this kind of alignment. One type that's maybe relatively easy are specialists who are really good at a certain kind of specialized procedure. So think, certain types of surgeons or others who are providing, very specialized services over a short period of time. What you need there is a good handoff between the primary care providers and the specialists for the time that they're in the hospital, having their complex complications managed by a hospitalist, or undergoing a major procedure like a bypass operation or certain types of GI surgery, and then a good handoff back, sharing data, good coordination. So we have some payment models that work there, those so-called acute episode bundles, which I think CMS is planning on expanding further, and it could be linked to performance measures and sharing data and care coordination. There are also some types of specialty care, and Larry, I defer to you, but maybe some, especially younger patients with IBD may be in this category, where the specialist can be kind of the main care coordinator manager, delivering that whole person care. The best developed care models and aligned payment supports in this area, in areas like kidney care for patients with advanced chronic kidney disease or ESRD, where the nephrologist can put everything together. And we've seen some successful models of nephrologists doing that, being paid more on a risk-adjusted, so-called person level basis, which gives them the ability to, not just get paid when a patient has dialysis or gets admitted to the hospital for a dialysis complication, but for preventing all of that. Then the third area is areas where you need both advanced primary care and specialists working together. And again, this is where I think the bulk of the spending and disease burden in U.S. healthcare is, especially for older Americans. This is the management of heart disease, especially people who have more advanced or complex cardiac conditions. It's the management of most musculoskeletal conditions, which often get referred to a specialist. And if you look at some of the analyses around the country, huge variations in surgery rates and imaging rates and injection rates that don't seem to be very much correlated with either good, evidence-based clinical guidelines or the outcomes that really matter to patients or to functional status, and also chronic conditions in GI, like inflammatory bowel disease, where we haven't yet put those payment models together. And so, our view, this is where nesting is most important, because it's very hard for the specialists in this space to manage a patient comprehensively without a strong primary care partner. But it's also very hard for the specialists to manage in the space if they're just getting paid for the acute episode bundles and not much for steps that they can take to coordinate with primary care and intervene in ways through digital technologies and supporting apps, e-consults, effort that I'm sure you're familiar with, Project Echo, that's been really important in helping support primary care docs who are treating patients with hepatitis C. They can't do it on their own. They don't need, the specialist doesn't need to do everything. We don't have enough specialists anyway, but there's not good financial support for enabling them to work together. So there are emerging models to do this that involve something like shifting the payments for the specialists involved in these chronic conditions that need some level of co-management and overall coordination with primary care, away from fee-for-service and into person-level payments that can be used for things like investing in a longitudinal patient tracker and early diagnostics, additional electronic consults, a team-based approach to care. Anything that the specialists who are in the best position to know would help efficiently improve the outcomes that matter for that patient. One reason I know, Larry, that we're not there yet is if you look at some of these chronic conditions where these models have been relatively well developed, and I'd still say they're way underdeveloped in areas like musculoskeletal care and some cardiac conditions like heart failure. What really matters most to patients with those conditions is their functional status and actually staying out of the hospital. And those things are almost it's the exception, not the rule, to track the results that matter the most for patients. We can't get to a health system that rewards and supports better health if we're not measuring it and aligning our payments and care models with it. As you know, we have good, well-validated measures of patient functional status and well-being could be and frankly should be the norm for being tracked over time as the goal of these coordinated primary specialty care models, but it's still the exception, not the rule. So we have more work to do. And I view that, Larry, as a top priority for our efforts at Duke-Margolis in 2024 and, however long it takes. It's now, as I mentioned before, a priority area for the Healthcare Payment Learning and Action Network. We're hoping to work more closely with PTAC, Angelo Sinopoli, who's the current chair at PTAC, recently joined our executive leadership group for the Healthcare Payment Learning and Action Network. And we're also trying to work with CMS and states and commercial insurers who are interested in these models, but are just having trouble getting them off the ground because, again, this is not the norm. This is not the way we've got all of our payment standards and billing approaches and so forth set up.
Well, Mark, I could listen to you forever. I do want to have one final question, and it goes right to the heart of what you were just talking about. Are we going to have to mandate this? Or do you think that this voluntary system we have in place is going to be able to show the willingness to implement all this? I've been a big proponent at PTAC of saying we need to put some type of a skeletal infrastructure into these population-based total cost of care models. What's your position on mandates?
It's very hard to get to, a significant change in medical practice to be the norm rather than the exception on a voluntary basis. And I'd say this is not for lack of effort. CMS has implemented a lot of voluntary payment reforms intended to support this shift. They've done a lot more, as I said, on those acute episodes. How do we have good coordination when there's a handoff for a major procedure or a hospitalization? They've done much more on that than they've been able to do on the longitudinal care coordination. But now that we've got a stronger base for primary care, I think we can do more there. Voluntary basis is slow. On the other hand, Larry, mandatory tends to provoke the stress reaction from healthcare providers when they hear that word. I wouldn't be surprised as we look ahead into 2024. So here's my prediction for specialty care and on 2024, since we're the start of the year. I wouldn't be surprised if you don't see much more from CMS talking about moving to mandatory models for specialty care in the areas where they've got the most experience with voluntary models, and that's those bundled payments for acute episodes. And again, I'm not saying that's a bad idea. I think it's one where we've got a lot of experience. Some people have criticized these voluntary models for saying they don't save money. My impression is that they do lead to some, at least incremental improvements in care. Unfortunately, the acute episode models are missing this huge set of opportunities around keeping people out of the hospital and avoiding the complications in the first place. But they do lead to some savings. The problem is if they're voluntary, the people who tend to sign up are the ones who are inclined to do this anyway and have already kind of done the math to show they come out ahead. So very hard to save money in those models. And I think you're going to see some more discussion about, well, can we move in a more mandatory path there? But what I'd like to see happen along with that, and this is where I hope we can continue to collaborate with SoNRMD and hopefully more of your listeners on the scope, is how can we make it easier to set up these contracts with specialists who share the interest of the primary care practices and some of the big hospital-based organizations that really want to move into a whole person approach to care? That's not all of them, but one thing that CMS could do is start producing some measures, as best we can measure, of things like, which specialists are doing more to spend time with primary primary care docs and co-managing patients on a chronic basis, which ones are doing better with following evidence-based guidelines or keeping patients out of the hospital. I know this is all challenging because you need risk adjustment and good data, but data are getting better, and there are plenty of successful models now. Some RMD has shown 15% cost reductions, more higher quality outcomes for patients. So let's make progress on making that more the norm. And along with that, maybe CMS could help support some templates or models and financial incentives for the primary care, accountable care groups, and for the ACOs to move away from what they're using now, which is still traditional fee-for-service for these chronic conditions, into maybe some starter models that have a piece of payments that's person-based and that includes an expectation that you're going to track a patient's functional outcomes and avoidance of measurable serious complications like hospitalizations over time, and a pathway to move even further away from fee-for-service and those primary specialty care areas of coordination, which again make up the bulk of healthcare spending in this country and the bulk of opportunities for really improving population level patient outcomes.
Well, thank you, Mark. Thanks to our audience for tuning in. You can access our podcasts on most all of the podcast platforms like Apple Podcasts, Google, Spotify, and others. Learn more about the show on the programs page on healthcarenowradio.com. Lend your voice to the conversation on Twitter at HCNowRadio. I guess I should call that X. Be sure to follow us at SonarMD. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.